Hi, my name's Emily Fridlington. I'm a dermatologist at Alamo Heights Dermatology, and my partner, Becky Kelso, who you'll meet later, and I are going to talk to you today about the top 10 most common things we manage in dermatology. So let's get started. One of the big reasons patients come in to see us is for something called onychomycosis. That's just a fancy word for nail fungus. Most commonly, toenails are affected, but fingernails can be affected as well. Typically, a toenail or fingernail that has a fungal infection will have certain characteristics. Those can include thickness of the nail, some discoloration, which could be yellow, white, or even brown-green. The nail can be brittle, which means it can get flaky and peel off, and it can affect either one nail or multiple nails. So here's a great picture of onychomycosis that's affecting several toes on this patient's feet. As you can see, the discoloration is whitish and the nails look a little bit thickened. This is another example, and this kind of showcases how the nails can get really brittle and look like they're peeling off. So how do we treat this nail infection? There are actually several options. First of all, onychomycosis, or a fungal infection in the nail, is not a medical emergency, and it doesn't necessarily have to be treated. So we have many patients that just opt to do nothing, and that's fine in several instances. The next type of treatment would be oral medications, and oral medications can be very effective, but when we're looking at our patients, we have to take into consideration other medications they might be taking and side effects from the oral medications. And the next treatment option would be topical therapy. And in the last several years, there have been some new topical therapies that have been very effective, and it's just like painting the nail with polish, really easy to do. So number 2 on the list is something called seborrheic dermatitis. Seborrheic dermatitis is just a common form of what's called eczema. And eczema is really just red, kind of itchy skin. The locations where people might have seborrhea are on the scalp, behind the ears, on the face, sometimes on the central chest, or what we call intertriginous areas. And a code for intertriginous is like private parts. The reason people get seborrhea is because of sebum, which is produced in the oil glands, and is also related to a very common yeast that lives on the skin called malassezia. What happens is that people develop these kind of red, and they can be brownish, patches that get very greasy looking, and then they get this kind of yellowish scale. Usually it only affects a few areas and it's pretty mild, but several patients can have more widespread disease. Sometimes it's very itchy, which can really bother patients, and that's often why they come in, especially on areas like the central face, where it may have more of a cosmetic concern. So these are some great examples of seborrhea, or seborrheic dermatitis. As you can see in the first picture, that young man has prominent involvement on the face, and you can see how it looks really red, and that scale looks almost greasy and yellow. In the second picture, you can see the involvement on the scalp, which sometimes looks like really significant dandruff. So there are lots of treatment options, and it's based on how severe the disease may be and how much the patient is really bothered by the seborrhea. The first option would be something easy to do over the counter, and that would be a form of an anti-dandruff shampoo. And there are lots of choices when you go to the pharmacy or the grocery store, things like Head & Shoulders, Selsun Blue, Nizoral, or T-Cell, all which can help lift the scale and have activity against the yeast that can be involved in this. They can be used on the scalp, obviously, since it's a shampoo, but also as more of a soap on the face or other body sites. Topical medications that you might try over the counter would be a 1% hydrocortisone cream, which is going to be anti-inflammatory, as well as Lotrimin, which is a yeast medication that will have activity against the malassezia. And those can be mixed together to form a nice paste. Okay, next is warts, and most people have had a wart. So the medical name for a wart is a verruca vulgaris. Now, warts are caused by a very, very common virus called the human papillomavirus, or HPV. Common warts are caused by particular HPV strains 1, 2, 4, 27, and 57. And the reason this matters is because there are strains of warts that have been involved in cervical cancer and things like that, and that's not what we're talking about today. So, what does a wart look like? Warts are hyperkeratotic, and that means thick. So you'll often see that the skin gets really thick on a wart. They can be dome-shaped, so elevated, and they're prone in sites of trauma, like the fingers, the hands, the knees, the elbows, and the feet. And that's because in areas of trauma, you can have breaks in the skin that allow that wart virus to take hold. A lot of people come in and they call them seed warts or black dot warts. And that black dot is just a dilated vessel that manifests as that discoloration in the skin. Autoinoculation is very common with warts, and what that means is warts are most commonly spread on a person from one site to another because of picking or touching them, or local trauma that then implants the wart in another site. So here's a great example of a common wart on the foot. And there are lots of ways to treat them. If you search the internet, you'll read all kinds of crazy things. And most of the treatments work because they cause some level of irritation in the skin. So at-home things that you might try would be salicylic acid, and that would be a product like Compound W or Dr. Scholl's. Some patients actually duct tape their warts, and they ask me if that really works. Again, the reason duct tape works is because it causes some irritation in the skin. Vinegar is a common product that a lot of people try over the counter. I think it's on websites probably. In the office, there's lots of ways we can torture warts. One of them is with liquid nitrogen cryotherapy, which can be a little painful. Candida antigen is an injection of basically a yeast protein. Canthrone is a medication that's actually derived from a beetle, and so it's a great treatment that doesn't cause a lot of pain. And then there are other types of lasers and injections that we can do. Okay, so the next big one is shingles. Shingles is also called Herpes Zoster. This infection or skin disorder is the result of the varicella zoster virus, which is in the family of herpes viruses. Varicella is the name for chickenpox, and zoster is the name for shingles, which represents a reactivation of chickenpox later in life. So shingles occurs in about 20% of healthy adults because they get run down or unlucky, and it happens in about 50% of people that are considered immunocompromised. So those could be people that have other medical problems or chronic illnesses. Reactivation, unfortunately, can occur at any time. And again, reactivation most typically occurs because of some stress or inciting incident in the skin. Typically, when the reactivation occurs, patients will experience what's called a prodrome. Now, that's been reported in over 90% of people, but it can vary. Some patients will describe some numbness in the skin. Others will feel some tingling, burning, itching, or some intense pain before the actual rash occurs. This is a dermatomal reaction, and what that means is that it follows a nerve. And what we'll see clinically, or when patients come into the office, are vesicles, which are small blisters, or redness. Sometimes we can see what are called pustules, so they almost look like little zits. Bulla, which is a big blister, or even just erosions or breakdown in the skin, which would be like an open sore. So here are some pictures of a more typical shingles. As you can see, it's in a line, which is that dermatomal distribution. You see a lot of redness, and then closer up, you can see that within those red patches, there are actually groups of small blisters. Here are two other examples that are a little different. On the one side, you have kind of bigger lesions and some that are actually open where you can see that kind of erosion or breakdown on the skin. In the second slide, you'll see more of that kind of pus bump look to the shingles. Again, noting that these are in a kind of linear distribution. Here's another example of a pretty significant case of shingles affecting the face. So how do we treat this? Treatment is with antiviral therapy. And the most important thing in treating shingles is that you want to make this diagnosis and get treatment early. Within 24 to 72 hours, treatment has been shown to reduce the duration of the breakout as well as the severity of the breakout and the symptoms. It also has been shown to reduce the complications of shingles, which can be pneumonia, hepatitis, which is inflammation in the liver, meningitis and encephalitis, which would be inflammation in the brain and in the spinal cord, and then something called postherpetic neuralgia, which is a description of nerve pain as a result of all that irritation and inflammation in the nerves. Lucky for us, there is a shingles vaccine, and that was FDA approved in 2006. This virus is called Zostavax, and it's a live virus. It's given as a single dose, and the reason it's only given in immunocompetent people is because it is a live virus. The recommendations are for healthy patients who are 60 years or older, regardless of their history of varicella or chickenpox or history of zoster. So now kids get a chickenpox virus, and people might say, well, we never had varicella, so how might they have problems with shingles later in life? But we're still recommending the vaccine for individuals over 60. And again, for the rest of us that are a little bit older and had chickenpox, shingles could be a real issue for us. Studies show about a 51% reduction in the development of zoster in people who have had the shingles vaccine, and most importantly, a 67% decrease in the nerve pain that can be associated with the shingles outbreak. And the next condition that we see a lot of is called cirrhosis. This is also known as dry skin. Dry skin can happen for a lot of reasons as people grow up. And one thing patients will tell me often is, I've never had problems with dry skin before. And I tell my patients, you know what, we accept that our eyes grow up and we have to wear glasses, our ears grow up and our hearing diminishes, and sometimes we have to wear hearing aids. Well, as our skin grows up, it has changes too, and those changes result in an increased likelihood to struggle with dryness. So in addition to age, certain medications can trigger dryness in the skin. Chronic diseases can trigger dryness in the skin. The climate, so if you live somewhere humid versus living somewhere cold and dry. And then personal care practices such as use of lotions, harsh soaps, things like that. Why does it matter if you have dry skin? Because ultimately, a lot of people have problems with itching when their skin is really dry. So here's a great example of cirrhosis or dry skin, and this is kind of, a severe example, but it's characterized by some redness and then some fine scaling. Some people say it has a dry riverbed appearance where the skin starts to crack and look like really a dry riverbed. Here are some other more mild examples where you see just kind of the redness and the fine scaling. And cirrhosis is luckily very easy to treat. A lot of it just requires a change in personal care practices. So if this is something you struggle with, you want to make sure you use mild soaps and cleansers. You want to avoid the really harsh drying soaps. You want to avoid uses of fragrances or products that are heavily fragranced because that can additionally irritate the skin. And one of the most important treatments is to use some form of an emollient. So an emollient is something that can be applied topically to the skin to help increase the moisture content and prevent this from happening. So in dermatology, we like to say creams or ointments are better than lotions. And that's because a cream or an ointment has a higher oil or lipid content than a lotion. My rule of thumb is if you can screw the cap off, turn the container upside down, and it doesn't come out, then it's thick enough for you to use on your skin. Mild keratolytics are also really effective, and a keratolytic is something that just helps slough the scale and keep water in the skin. And those would be products like ammonium lactate, salicylic acid, or urea, and those can be found in common over-the-counter products as well.
Hi, my name is Dr. Rebecca Kelso, and you just met my partner, Emily Fridlington. We're both with Alamo Heights Dermatology in San Antonio, Texas. And I'm going to continue the Dermatology Top 10 by talking about something called Actinic Purpura. And that basically means bruising. And it is something that I have my patients show me at least several times a week, if not a day, because they're very bothered by it. It typically manifests on the forearms and hands. Usually they don't even remember any sort of trauma, or if there was trauma, it was very minimal. And basically it's due to fragile skin changes from sun exposure over a lifetime. So not anything the patient had recently, but just small little increments of sun exposure throughout their entire life. It's definitely more pronounced in patients on blood thinners such as aspirin, Coumadin, Xarelto, but also other things like fish oil pills, vitamin E, or Advil type products can make it worse as well. I've found some success with an over-the-counter lotion called Dermmen that you can find in your drugstore. And here I just wanted to show a little bit of a slide for a normal skin that's probably not been sun exposed very much, or maybe on a very young person, and compare that to this picture, which you can see as opposed to that very bright pink thick bundle of collagen at the top layer of skin. It looks more wavy and light blue and not quite as healthy. So I'm just going to show that healthy skin that's not sun exposed there with that light blue color. And where that light blue color is where all of our blood vessels are in our skin. So you can tell if that supporting structure has gotten weaker, it's going to make those blood vessels a lot more fragile to even minimal trauma. So that's basically what's going on with the actinic purpura. But it's not anything bad or dangerous. And you can always try that Dermmen if you're looking for something to help it along. The next slide is something called Actinic Keratosis, and this is also fairly common, definitely more common in patients with lighter skin colors, although I can see it in patients with more medium skin tones as well. It is a precancer that manifests as red scaly bumps on sun-exposed skin. A lot of times you can feel them better than you can see them, and then sometimes patients will feel like they have a sticker burr in their skin. They're precancerous to squamous cell carcinoma. It's very treatable with liquid nitrogen, and there are other topical medicines that target the atypical cells. There are also, there's an in-office procedure called photodynamic therapy that targets these precancer cells as well. If you're looking for prevention, you want to try to use daily sunscreen, hats, and protective clothing. And this is a skin cancer type that those precancers can progress to if they're not treated properly. And in about 10% or so of the time, those actinic keratoses that I just talked about can progress to the squamous cell carcinoma type of skin cancer. Here's an example of that on the lip. And they, again, can present as scaly red bumps on sun-exposed areas. This is the second most common type of skin cancer. You can treat these by surgery or radiation. Sometimes if they're very superficial, they can be treated with topical medicines as well. And again, prevention with daily sunscreen, hats, and protective clothing can prevent these areas. This next picture is kind of a subtle case of a most common type of skin cancer called basal cell carcinoma. If you look on the bridge of her nose and the top of her nose, you can see it's kind of a little shimmery pink area that reflects the light a little bit more differently than the rest of her skin. Here's a little bit more obvious example of this type of skin cancer. Again, you can see the light reflects off that bump a little bit differently than the rest of the skin. It has maybe some more dilated blood vessels than the rest of the skin as well. And these are usually very slowly growing bumps that just won't go away, or maybe just this pimple that's been there forever. And again, sun-exposed areas are the most common sites. Treatment can be with surgical removal or scraping and burning these spots away. Radiation is an option as well. And again, like all of these cancers, prevention consists of daily sunscreen, hats, and protective clothing. This is one of the most common complaints we see in our office. It's called a Seborrheic Keratosis, and it is totally benign. They can look very dramatic and be in different shades of gray or brown or pink, and they kind of look almost warty to the common observer. Here are some more examples of that. And they can pretty much be found on almost any area of the body. We call them the gift of time, so the more time you get on this earth, the more of these you may have. They tend to come up in areas of friction, such as underarms, bra strap areas, waistbands, but again, they can appear anywhere on the body. They may be frozen off, no treatment is necessary. And this is also a very common disease we see. It's called inner Trigo. It's not anything bad or dangerous. It tends to favor the areas of skin folds where skin's touching skin, so maybe under the arm or under a bra area, or maybe if you have a little bit of a tummy where the skin touches skin, it can hang out there as well. So these are pink areas on the skin. Usually it's a mixture of inflammation and yeast overgrowth. And prevention and treatment basically is targeting moisture due to sweat or occlusion in these areas. So keeping a healthy body weight prevents the risk for these skin folds to be developing. And then again, thoroughly drying the areas with a towel or even a hair dryer on cold after a bath or shower prevents development. If you're having an active rash, you can always get that mixture that Dr. Fridlington told you about, which is over-the-counter hydrocortisone cream and clotrimazole cream or Lotrimin. You mix that in equal parts twice a day, and any of those really active red areas can help those rashy spots go away. And finally, this is a rash called Stasis Dermatitis. This is a lower extremity of a patient, and this patient may have come to the dermatology clinic sent by their primary doctor, perhaps for a case of what they thought might have been cellulitis. It can be bilateral on both legs, which usually cellulitis is not. And stasis dermatitis is basically an issue where you have venous insufficiency. So the leg veins in your lower extremities aren't doing quite the job they need to push that blood back to the heart. So it's kind of static there. And once that happens, it can create a lot of inflammation in the skin, or almost like an eczema type condition. Treatment consists of efforts to decrease edema through leg elevation, compression stockings, and then topical steroids to treat the leg inflammation. And these images we got from a textbook called Bologna, so we appreciate that, and thank you for your attention.